Imagine an elastic mesh that keeps our skin springy. When body weight changes abruptly or the body rides a hormonal roller coaster during pregnancy or the teenage growth spurt, that mesh is stretched so hard it tears in places. Those microscopic tears in collagen and elastin fibers first appear as pink-purple ripples called striae rubrae. Blood vessels rush in, inflammation flares, and the skin promises to patch the damage. Yet the patch is woven not from ideal type I collagen but from more fragile type 3 collagen that contains little elastin. A few months later vascular activity fades, the scar pales and sinks, becoming striae albae. Patients often ask, why did my friend's belly bounce back after childbirth while mine didn't? Genetics plays a role. The amount of fibrillin in the dermis is largely predetermined at birth. Two women with the same weight gain and the same cream can therefore end up with very different outcomes. Still, even with bad genes we can tip the balance. Stabilize cortisol, avoid yo-yo weight changes, hydrate the skin regularly, and keep protein intake adequate so the body has the bricks to build proper collagen. I advise pregnant patients to apply rich emollients twice a day from the second trimester. It is no guarantee, but it buys the skin extra time to expand without tearing. During the fresh, pink stage we enjoy a 6-month window of opportunity. Our goals are to quell inflammation, nudge fibroblasts to lay down healthy collagen, and prevent the scar from going white. First-line therapy is a 0.05 to 0.1% topical retinoid every other night. It makes keratinocytes proliferate faster, thickens the epidermis, and stimulates type I collagen in the dermis. For the first weeks patients complain of mild flaking, part of the process. In the morning SPF 50 is mandatory. Ultraviolet loves to turn inflamed skin into pigment spots. Second-line support comes from hyaluronic acid combined with vitamin C serums. Hydration plus antioxidant means a friendlier milieu for collagen synthesis. Hyaluronic acid upregulates the COL1A1 gene, while ascorbic acid acts as a cofactor for proline hydroxylation in the collagen helix. At night I add silicone gel sheets. They create an occlusive microclimate, decrease transepidermal water loss, and physically protect the scar from further stretching. If a patient sticks to this scheme for 12 weeks we often see the width of striae shrink by a third. Not magic, just biochemistry, time, and discipline. When 4 months yield less than a 30% improvement, I explain that it is time to bring in devices before we lose the vascular, chestnut, tone that still contains options. When creams fall short, I move to control 2, microneedling. A sterile 1.5 mm roller makes hundreds of microchannels. The skins, alarm and repair, cascade triggers, and fibroblasts are signaled to spin better quality fibers. 5 sessions, 1 every 4 weeks, add roughly 20% dermal density, which in practice means visible narrowing and smoothing of the striae. We boost the effect with platelet-rich plasma injected right after the needles, growth factors from the patient's own platelet speed remodeling. For dark skin or clients prone to post-inflammatory hyperpigmentation I prefer microneedle radiofrequency. An insulating coat shields the epidermis while high-frequency current heats the dermis in pinpoint fashion. Temperatures of 60 to 65 degrees Celsius are the sweet spot, hot enough to denature old collagen and trigger neocollagenesis, yet gentle enough to avoid carbonization. Most patients feel warmth and tingling. Recovery lasts up to 3 days. Deep, ivory white striae benefit from carboxytherapy. Medical CO2 injected under the skin causes a local bore effect. Temporary hypercapnia dilates vessels, tissues get more oxygen, fibroblasts work easier. Very wide, sunken streaks can be filled with nanofat. Finely emulsified autologous fat carries stem cells and immediately lifts the depression, evening the skin's topography. Every method has contraindications: active herpes, pregnancy, poorly controlled diabetes, autoimmune dermatosis, so we always run baseline labs and take a thorough history as if drawing a risk map. When a patient arrives saying, "I want everything you've got," and the striae are over a year old, I reach for the fractional CO2 laser. Microbeams vaporize tissue columns less than a millimeter across, leaving bridges of intact skin so healing is faster. 3 sessions 6 weeks apart can have the depth of the groove. Fair-skinned clients love it. Darker phototypes I steer toward non-ablative 1540 nanometers. It heats the dermis without damaging the stratum corneum, lowering pigmentation risk. To lock in gains, I schedule a single microneedle RF session 3 months later. Radio waves deliver energy precisely where CO2 has already prepared the ground. Meanwhile, the patient uses a 0.3% retinol cream and silicone gel nightly, and in daylight a broad-spectrum SPF 50+. Recovery is straightforward: pH-balanced cleanser the next day, dexpanthenol until erythema fades, cool compresses for the first 48 hours. We do the final review 12 months after starting the program. The before and after photos speak louder than any words. While I, as a doctor, am honest, stretch marks can never be erased perfectly. Modern technology can make them almost invisible and, more importantly, give the patient confidence in their own body again. Beauty starts not in the mirror but in how we feel, and medicine can help enormously with that.